I want to thank all the speakers who are here this morning, who traveled from far and wide. Dr. Kearns actually came in from Maryland to be with us this morning. Dr. Kearns runs a genetics lab, and when the email went out, the information went out for this symposium, we received responses that he's such a wonderful speaker, down to earth. He takes the most complicated, the most sophisticated material, and he makes it manageable. He understands what we understand, what we don't understand, and he gives over that information with such clarity. And it's a real privilege to call upon Dr. Kearns. And again, I thank all of the speakers. I'll introduce them but before I continue, I do want to thank all of the speakers, all of you for coming, and especially I want to thank Mrs. Davidson, Leah Davidson, who's our executive director, who works so hard to make sure that every single PUAH program works and it functions well and is successful. And Baruch Hashem, she's here. Her mother is in the hospital, and Baruch Hashem, she's here. And I do want to dedicate this morning's program for the Refuah Shlema of Esther Bas Shendel, Bez Hashem Shishtev Refuah Shlema. And without further ado, Dr. Kearns.
This is forward. And you have the red dot if you press it. Okay. Thank you very much. Thank you, Elon. The check is in the mail. Or in your collection basket. I'm Catholic, that's all I know about. So you said to me when I got here a little bit late, you said, that's okay, we're Jewish, we always run late. So I said, what does that mean about Catholics? Because we're even worse. Thank you for inviting me. I really appreciate that. And this is near and dear to my heart because as a geneticist, I see a lot of catastrophes out there that don't have to happen. Some we have no control over, but some, we can preemptively reduce that risk. All right, you can't make it zero, but you can really reduce it. So I'd like it to be interactive. If you have questions, please do. I will stay afterwards to address any other questions too, and I'm happy to help any way that I can. So yes, I'm a professor at Johns Hopkins Medicine and Genetics. Did my fellowship there, so I've been there for a long time. I also am the head, I founded actually Advogenics. I'm the president and scientific director there. And it's an all-encompassing genetic testing laboratory in Maryland. This is where it all started for geneticists with a monk planting peas and showing that different things can be mixed and you get different colors and different sizes and so on and so forth. This is what genetics is really all about for all of us here. You have a mother or a husband and a wife and then a child. I think the ice cream cone should be for the child. I stole these off the internet, just with fair. So if there's any copyright lawyers out there, please don't. And this is really how it all works. I mean, our nucleus is in the cell. There are mitochondrial genomes that play a role for energy and things like that, but primarily our main genetic information resides within the cell, within the nucleus. Chromosomes are here. That's where our genes reside. When I talk to patients and I'm trying to explain, like if they have reproductive loss because of an abnormal karyotype or a balanced translocation, I describe these as pencils and red-green pencils to visualize those. So all of our genes are on the chromosomes. The genes itself reside within our DNA, and what we're really looking at are DNA changes or mutations, pathogenic mutations within the nucleus itself. More than 80% of babies born with an inherited genetic disease have no known family history. Let's let that sink in a little bit. I recognize that Ashkenazi Jews do have a higher incidence, but if you think about other ethnicities, they have no clue. They just don't have a clue. So 80% of the time, when people find out that they have some type of pathogenic mutation within their family, they have an affected child. And by the time that happens, it's too late. Make sense? The different types of genetic transmission of diseases, autosomal dominant means that if you have the mutation, you have the disease. And you can see this is what we geneticists call a pedigree. So this would be you know, mother, father, children, Mary, children, but on this side, she's affected, and it goes to her two affected children. So one way of looking at a dominant mutation is that you see it in every generation. Recessive disorders is what we're primarily talking about here, where the husband and wife have to pass on that mutation to their child. So carriers of recessive mutations are unaffected. So Gaucher disease, husband and wife could be carriers, but they have no disease. They don't know it. So there's a 25% chance of passing that on and having an affected child. And the significance in a pedigree is you don't see it in every generation. It's rare, but you know, Fragile X is also something that we need to look at. That's an X-linked disease. Women have 2 X chromosomes, men have 1. And we have a little bitty Y chromosome that doesn't do anything. So if the ladies are going to make fun of us, I said it already, it does nothing. But on X-linked disorders, the woman is an unaffected carrier 99% of the time. Her risk is she passes that X chromosome on to her son, and then he is affected because males only have 1 X chromosome. Women have 2, so the mutation she has, it gets inactivated in women because all this 1 X chromosome gets inactivated in women for dosage. So I'm just going to read a couple of these things. The Jewish community is at an increased risk for many genetic diseases that occur more frequently in this population than others. Genetic diseases commonly occur in isolated communities. Jews of all backgrounds should consider carrier screening because they are all at risk to be carriers of genetic diseases. 85% of Jewish Americans have an Ashkenazi Jewish background. Families came from Eastern Europe or Central Europe, and 1 in 4 are carriers of a recessive disorder. 25% of you sitting in this room are carriers. Do you know that? You know, have you been tested for carrier screening? You know, I don't have to give you history lessons. You know a whole lot more about it than me, but the 3 types of Jews. So carrier screening, you know, what is it? You know, again, we're testing primarily for autosomal recessive disorders, but we can also test for X-linked, and if the patient wants it, we can also test for autosomal dominant disorders. When I go around talking, I do a lot of lectures and things like that, and when I have a room full of doctors and I say to them, how do you choose which carrier screening panel you're going to use? And what I overwhelmingly hear back is, oh, I depend upon the genetics company. You know, they tell us which ones are most prevalent for us and things like that. That's not the right answer. The answer is all genetic companies try to be unique and specialized and try to offer more types of tests, right? I can do 175 tests for carrier screening. You can only do 114 or whatever. My argument is there has to be a reason for doing the additional tests or don't do them. So let me give you some examples of why some genetic mutations are highly representative in certain ethnicities. Cystic fibrosis is an autosomal dominant disorder. Again, it's recessive. Both parents have to have the mutation, and they have a 25% chance of both passing that on to their children. And the child has CF. Well, the reason it exploded is in Caucasians, that's the most common mutation we have. The reason it took off so much was because if carriers only have 1 mutation of cystic fibrosis, they were resistant to the cholera toxins way back when. So cystic fibrosis is a channel that moves fluid in and out of cells. They were resistant to cholera toxins, so they had less vomiting, less diarrhea, So they were more resistant to that, and they didn't die. That's why the mutation increased in the prevalence of the populations. Sickle cell. In Africa, sickle cell is a sickling of a red blood cell, and red blood cells carry oxygen. So when they sickle, the patient can be in great pain, the patient can die. Malaria also infects red blood cells. So carriers of sickle cell were more resistant to malaria way back when, and that's why it took off in time. So, and I stole this from the Jewish genetic disease, so I'll say that. Here's a list of what are the diseases common to all Jewish groups. And I'm not going to go into all the specific diseases. If you have specific questions later, I will be here. I have some cards over there. I'm terrible about carrying cards. The rabbi has my information. Feel free to reach out to me anytime. I'm happy to help any way I can. So these are the diseases common to all Jewish groups. These are the diseases common to Ashkenazi Jews. So I want you just to compare that. That's what's common to all Jews. This is what's common to Ashkenazi Jews. And even more. And there's also, you see this down here about BRCA mutations. BRCA mutations, BRCA1 and BRCA2, they're genes associated with breast or ovarian cancer. So if you have a mutation, it doesn't mean you're getting breast or ovarian cancer. It means that you are at increased risk of getting it. We do a lot of inherited cancer mutation testing, and I feel very strongly that people get pre-test counseling and post-test counseling to explain to them what it means. So women have a BRCA mutation. We talk to them about what their lifetime risks are of getting breast or ovarian cancer. And it also plays a very significant role in their ability, in what their family history is. Do they have any first-degree relatives with breast or ovarian cancer? That increase their risk too. So not only are Ashkenazi Jews, all right, let me figure it. My wife says I can't do the remote control, and I can't. So not only are you at risk for all of these, but you're also at risk for breast or ovarian cancer. So the JGDC provides information about diseases that are commonly found in the Jewish community and would be important to be included in a carrier screening panel. But pay attention to the yellow, please. Please keep in mind that the availability of testing for these diseases might differ between labs, and it is important to discuss your options with a genetics professional before being treated. When carrier screening first came out for the general population, I don't know, 8 years ago, whatever, counsel came to me and asked me my thoughts on that. And I had some concerns, not about the testing, but how the information would be transmitted to the patient. And would the patient be able to understand it? Because again, these are primarily recessive diseases and X-linked diseases. If you have the mutation, it doesn't mean you're getting the disease. And also as a geneticist, I'm not, back then, I've changed my mind. I wasn't all that keen about population screening because that has a whole new difficulty out there with insurance and with everything else. It can be challenging. And that's what turned out. So what happened were patients were being tested. They got the report back. I criticize doctors all the time, including me. Doctors are very bad at asking someone for a clarification about what does something mean. They like to think that, we like to think that we know everything. I'm very, very heavily involved, and I've been very heavily involved for 15, 18 years, something like that, I can't count, in testing embryos within IVF clinics. And while the reproductive endocrinologists, the IVF docs have great expertise in IVF, they have limited ability to keep up with genetics. And I'm the same way. I still walk around when somebody says day 3 hormone levels. I say, what is that? I mean, you'd think I'd know what it is after 15 years or something, but I don't. The point is, all the people, these specialists and clinicians need to work together so we all give the patient a clear understanding of what the testing is and what it means. So what we do, and what I insist Avogenics does, is every patient that does carrier screening, before they do it, they get a genetic counseling consult, either with a genetic counselor or with myself. And they're explained what it is, what it means, and why you're doing the testing. Ethnicity is discussed, all of that. Different panels are discussed. Why should we use this panel versus that panel? After the testing is complete, the patient gets a call. It's all reviewed again, what it means. If it's negative, it's negative, but what is the genetic significance to them? I feel very, very strongly with that. And I will not do any testing within Avogenics unless a patient agrees to all that. And quite frankly, I don't care what the ordering doctor wants. If the ordering doctor says to me, and some do, well, I can explain to the patients. Sorry, I'm going to explain to the patients, with all due respect. And I stole all these pictures. I love these pictures. What screening should you do? Anybody have any thoughts? Let me say this also about genetics. You never told me how much time I have either. So whenever you want to go, that's it. That's 5 minutes. How about that?
That was 3 minutes ago.
I'll take your check back. I won't put it in the mail. So what screening should you do? Years ago, I felt pretty comfortable talking to patients and getting a pretty good understanding with their questionnaire and things like that, what their ethnicity is. I don't anymore. And I think I was wrong back then, because I think we're all such an admixture of things, it's hard to really tell. So in many ways, populations that have higher incidences of different diseases, it's easier for us to really identify that, and we can make better recommendations to the patient. So what should you do? I just said all that. This is what we offer. I require pre-test counseling. We use blood, saliva, or buccal swabs that can be sent into the lab, and they get post-test counseling. Normally, the wife gets tested first. I prefer we test both, because just for the proper information for the family. They should have that information prior to pregnancy, whether it be natural or IVF. If they have mutations and they're at risk of passing them on, then they can go through IVF and do pre-implantation genetic testing. IVF started in this country, with Dr. Howard Jones. He's the smartest man I've ever seen. He was in Norfolk. He was actually at Hopkins, and I'm a Hopkins snob. He was at Hopkins for a long while, and it was retirement age, and he and his wife, Georgiana, moved to Norfolk, Virginia. And conservative Virginia allowed them to set up a IVF program, which was really surprising to me, but they did. I didn't know Georgiana very well, but I did know him, and they say she was a hell of a lot smarter than he was. And he was just something remarkable. But they had the first baby in the United States. This is the first baby ever, Louise, with the people at Bourne Hall in the UK. And I met her 2 years ago. She's absolutely remarkable individual. This is steptoe. There's the baby, and it's something. This is Bob Edwards, the embryologist. This is the first IVF baby from the Joneses, and I actually met her a few years ago too. So they're remarkable. So the process of testing embryos within an IVF cycle is the eggs are retrieved. Basically, it stimulates you're giving gonadotropins to stimulate your follicular development. Eggs are retrieved, sperm fertilizes the eggs, the embryo is biopsied, it goes to a genetic testing facility, recommendations are made what are normal and abnormal, and then the embryo is transferred. Not only should one do, let's say, Gaucher disease, but we also make patients do aneuploidy testing or chromosome testing, because chromosome testing is the most common cause of reproductive loss for any type of reproductive loss, from plants to humans and everything in between. And you can see here, over 80% of embryos are aneuploidy for women over 40. And I hate that phrase, advanced maternal age. That's a bunch of blank. So this is what you're trying to avoid. What about variation in our children? I mean, I had a question before about different things that can happen, but what about just general variation? I didn't actually steal these, because these are mine. These are my twins. This is my son, Will. This is my daughter, Kate. She was a really ugly baby. And I told, don't be offended. I told her that, too. Well, she married Trey. Here's Kate and Will as they got a little bit older, and Trey. She turned into a swan, that's for sure. That's Trey. And that's my grandson. So my third son, or my second, I have two sons. I can't even know how many sons I have. I have the twins and I have a younger son. What about designer babies? I look at it a little differently. Patrick, he came from the stork, because he's totally different from any of us. He is absolutely unique and different. And maybe he had to, because he's 2 years younger than the twins, and everybody goes, oh, twins, twins, well, what about me? So maybe he did come from, but that's baby Patrick, and that's Kate and Will. Thank you.
Thank you very much.
My pleasure.
Okay. And as Dr. Kearns said, he'll be available after the presentation to address anyone's personal questions.